I think it's fair to say that for patients with localized prostate cancer, there is at present limited data that suggests that it's really something that we can already use and implement to monitor to see whether the radical prostatectomy has been successful, whether biochemical recurrence is coming up. So I don't think that the current data are sufficiently underscoring its clinical utility. The studies are relatively small, and there's a high number of patients that do not show CTCs with the current methodologies that are being used. In contrast, patients with a much higher tumor burden, so more the castration-resistant patients that need to undergo systemic treatment, or in whom we know that treatment resistance has developed, and that we really need to select the patient in order to see which treatment he will benefit from. I think there's many more data showing that yes, CTCs can be used, although all these studies have been done in a more or less research setting, that for instance, expression of the aberrant abnormal androgen receptor, the androgen receptor V7 splice variants, for instance, that can be demonstrated within the CTCs, that expression and the presence of such AR-V7 positive CTCs really predicts the outcome of treatments that are targeting the AR signaling pathways. So it's very clear that if a patient has AR-V7 positive CTCs, that enzalutamide or abiraterone treatment will probably be not so successful as compared to the ones that do not have these abnormal androgen receptor expressing CTCs. So yes, I think there are sufficient data now to show that CTCs have a prognostic value. If you have loads of CTCs, probably your outcome is going to be poor in a metastatic setting. If you're responding to treatment with a decline, more than 30% decline of CTCs, it's telling us, it's giving us information that the patient will fare better, that the disease will fare better as compared to those that do not have a drop in CTCs upon treatment. And by using, for instance, this specific marker like the androgen receptor V7 splice variants, I think we are able to select patients, yes or no, for treatment with AR signaling inhibitors like enzalutamide or abiraterone, which of course are also quite expensive treatments. So that is, I think, very useful. If you would say how statistically sound are the data, I do think that we need more data. We need more prospective trials. And in particular, I think that CTC measurements, counting the way to select them and to study them, may be cumbersome. It depends on the methodology, and it could well be that another method in which we also use taking a blood sample from a prostate cancer patient and measuring DNA and DNA abnormalities that are derived from the patient's own tumor cells, that these cell-free DNA measurements may well pick up very rapidly in the near future. And it would be great to see whether we can compare CTC measurements with cell-free DNA measurements, because cell-free DNA measurements in the end may provide us with a more broader tool to measure specifically those antigens of interest, those genes that are abnormal, for which we also really have specific treatments. So I think the future is bright. The clinical utility of CTCs is better proven in the CRPC setting with high tumor burden, but I think that to select specific treatments will be really very important in the near future, in using CTCs or cell-free DNA or even the combination or measurements of exosomes.